We want to thank you for joining us today. This Friday Focus for Health is hosted by the Great Plains Quality Innovation Network, the Centers for Medicare and Medicaid Services, Quality Innovation Network, Quality Improvement Organization for North Dakota and South Dakota, and we'll focus on looking at vaccinations through a different lens. Today's webinar is being recorded and will be posted within 1 to 2 business days on our website at greatplainsqin.org under the Friday Focus for Health link at the top of our homepage. We will also share that link with you. There's also a resource handout that includes all the resources shared during today's session, and you can access the document through the link that will be placed in chat if it hasn't already been. And of course, if you have any questions, please add them to chat. We want this to be interactive, and better yet, if you want to come off mute and ask a question when we have time for that, that would be great too. All right, hold on just a second here, and we'll get to the next slide. There we go. Okay, so today's topic is Snapshot of Data and Immunization Information Systems, or IIS as they're called. And we have Andrea Polkinghorn, who is the lead immunization strategist at Sanford Health, and she's also the president for Immunize South Dakota. So Andrea, I'm going to let you take it away. I'll stop sharing and you can go ahead and share your screen and give a little background on yourself, and we're looking forward to your presentation.
Yeah, thanks for having me. So as Dee said, I work as the lead immunization strategist at Sanford Health. Been in this role for, I think it's 7 years now. Been the president for Immunize South Dakota for a while now as well. So I do this work day in and day out. So I'm so excited that they're hosting a presentation about this. As Dee said, my background is I'm a nurse. So that being said, I'll just jump in because I know we're on limited time. So I wanted to start today just reviewing some adult immunization rates and talk about the resources that are out there as far as statewide or nationally. So adult immunization rates are actually very, very poor. I don't think a lot of people recognize this. And when we do focus on adults, we tend to focus on 65 plus. But we do a better job there. It's everybody like 18 to 64 that we really need to do a better job with. And so this is data that I pulled from CDC's Adult Vax View. And so for high risk adults, so those with, chronic heart and lung issues who should really be getting these vaccines, people like diabetics, you'll see there that the rates are in 30%. Only 30% of these adults are up to date. When we look at that 65 plus population, we do see a jump up into the 70s, which is good, but we could still do better. And then when we look at something like shingles rates, you'll see nationally that's only about 40%. We are doing a little bit better in the Midwest here in the 50s, but nonetheless, I think we can all agree that only half adults being protected with their shingles vaccine is not ideal. This graph, what I really wanted to show you is that we're not really making any improvement. And we kind of see the same thing with flu. So it's like, we do so much work, we work so hard, but we're not really getting anywhere. We're not doing any better. And so part of it, I think, is just really a lack of awareness, both from the healthcare professional side, because there's not a lot of external reporting that's required aside from 65 plus. But also the public's awareness. We have more vaccines that are routinely recommended for adults now than we ever have before. But I think there remains this perception out in the public that primarily vaccines are for children and adolescents, which isn't true anymore. This is what I was talking about with the flu too. This data is from 2020. So you'll notice a spike at the end here as everybody was nervous about, a twindemic. And so we did see a boost in flu rates. Historically, what happens when we see that we do a better job vaccinating followed with less disease as we see a drop in rates the following year. I think this one's challenging too because we have to start over every year, and really push this. And there's a lot of myths and misconceptions, about the value of the vaccine, even if you still contract influenza, and stuff like that. And so I think us as healthcare professionals have to have a better understanding of that to really navigate some of these conversations to provide context to people. So nonetheless, you'll see that we do the best here with older adults, 65 plus. When you look at that high risk group, that 18 to 49 and even 50 to 64 that I was talking about, you'll see that those really lag in comparison. So definitely some work to be done. And some more data that's out there, and I think this is a great example, even though it's national data, they do provide you an opportunity to drill down to the county level. So I also wanted to call out, you can compare rates across time, right? So when we look at this graph on the left here, there's much more blue, meaning we've done a better job vaccinating. And so when we compare that to who's had a booster, a bivalent booster, you'll see the colors are much less, meaning we did good in the beginning and now people aren't really getting them anymore. So that would clue you into potentially opportunities to evaluate why that is. I think another thing that I want to call out, and I know this from my role at Sanford because we're primarily in North and South Dakota, is that we see greater hesitancy on the western side of the state. So you'll see in particular on this graph for sure, lighter colors. And so that's just another way to look at the data to say, hey, I wonder what's going on in these communities. Why aren't we doing as good of a job? And we'll talk about some of the barriers that there may be in a minute here. For those of you who live in South or North Dakota, your Department of Health has a fabulous immunization dashboard. I actually use it a lot. So they have 4 different dashboards. There's an infant, childhood, maybe there's 5. Infant, that includes children, sorry, adolescents, adult, and flu, 4. This is the picture of the adult. So you'll see you have all the different vaccines on the bottom here. Again, this is trending across time. So you can evaluate, are we doing better or worse? And then there's the individual rates over here. Then the next tab on these dashboards is that county level data. And I know if it's not the next, oh, it is the next slide. So this one here, when you click the next tab on these dashboards, it gives you county level data. So again, kind of what we talked about when I'm looking here, I'm like, oh gosh, what's going on with the green? We got worse rates. Again, that western side of the state. So I think that alludes us to digging in. So whether you're a clinic or maybe work a little bit more in public health is really identifying who's in the vaccine space in those communities to figure out what the issues are so that we can work to overcome them together. This slide here just talks a little bit about rural versus urban. And so we usually do see some disparity here, in particular in the Dakotas, knowing the rural nature of our state. And so, yes, so the red bars here being the urban and the green being the more rural areas. So again, that'd be something to cue us into what the barriers could be. So initially, some of my thoughts that come to mind are we have a lot of farmers. Sorry. We have a lot of farmers, right, in rural areas of our state. It's hard for them to get away to go seek a vaccine. We know that access may be an issue to vaccines. So is there a vaccine provider there? What are their hours of operation? Things like that. And then I think it existed before, but it's only been exacerbated, is really the politicization of vaccines in this sense, particularly in our conservative state, is this like autonomy, right? Don't tell me what to do. I should be able to do it if I want, but not really understanding our goal of public health and how to ensure that we're protecting everyone. Then we usually see disparities in gender as well. Sometimes this cannot be as big among certain vaccines, but it's bigger in others. This graph here is from that North Dakota Department of Health again. It's the rate disparity between males and females for pneumo 65 plus. And so I think when we think about just women and healthcare, they're usually better about scheduling appointments for themselves and their kids, and men not so much. So that could just be part of it, but definitely something to be aware of to see if maybe there's some work that needs to be done in that area. You may have heard about this through the pandemic, but there are different races or ethnicities that seem to experience greater hesitancy and have lower immunization rates. So in particular, Blacks, we see this with some distrust based on prior history that has happened to those individuals. The purple here is, American Native. So I think that would be of interest to us in the Dakotas, knowing that we have several reservations within our footprint. And I should call out with that, it's good to know that there is some data limitation, and we'll talk about ISS in a minute, but there's some data limitation as to how accurate our records are coming from the reservation. It seems they probably do a better job with children as far as ensuring that documentation is in there, but maybe not quite as well with adults. We also experience some data gaps with things like the VA. Their system just doesn't interface, and they don't, dual document. And so there are instances where when you dig into this data, you may find some of that is painting potentially an inaccurate picture, is a good way to say it. So why aren't immunization rates better for adults? Why aren't they getting vaccines? So when I talked about, I think there's a lack of awareness about all the vaccines that are needed for adults. So those high risk conditions, and really why those chronic conditions place them at an increased risk. There may be insufficient access. So not everybody can get away from work to go seek vaccination during normal business hours. And so things like weekend or after hours clinics or increasing access through things like an urgent care can really be helpful to those who struggle to get away from work, for instance. We know we have hesitancy. There's been so much in the media. This wasn't new. It's been long standing, but I think that in conjunction with the plethora of like mis and disinformation and the ability to share that on social media with millions of people only exacerbate the issue. So when you guys think about other quality metrics that you're working on, like mammograms, colonoscopies, they don't have a well-coordinated, well-funded opposition group spreading myths and telling people why they shouldn't get it. And we have that in the vaccine space. And so it just makes our job that much harder, but definitely highlights the need to put some effort and work in the vaccine space. I talked about it on a previous slide is really that politicization. I think being in this conservative state is probably a little bit worse here for us. And just really that personal individual autonomy, people wanting to make medical decisions for themselves. There is a perception that these vaccines are no longer needed because the diseases aren't occurring within our state. So one of the things that I've been doing at Stanford to help overcome this is to monitor the epidemiologist's office has an infectious disease dashboard, and we put that in our weekly newsletter. And that's really just to highlight, to increase awareness that these diseases, while they're occurring significantly less frequency due to vaccines, they do occur. And if we let up on our immunization efforts and our rates decrease, we're just going to be more at risk. In the state of South Dakota, we do not have an immunization program for adults. In North Dakota, you guys do have a 317 funded adult immunization program. The challenge with those is that people have to sign up to be a provider under that program. and follow the requirements. And B, it doesn't have all vaccines. So it is helping definitely, but a vaccine like shingles won't be on there because the cost of the vaccine is too much to offset it. And then another barrier that we have is having to start over, right? So we see that with flu every year. And I think COVID, as the recommendations change and we have to keep giving boosters and things like that, it's really hard and can be disheartening to feel like we're making any improvement. Just a couple of other things regarding perception. This isn't a direct quote, but it's something similar that I heard from the North Dakota legislature, a representative last year, and it was, you all said COVID-19 vaccines would be 95% effective in preventing disease. Now we need new vaccines and additional doses because you all lied. Which I think we all know we didn't lie. We get new information and things change. And then we have to evaluate that and make new recommendations based on that. But I'm just trying to highlight how maybe the public perceives those things. And so this is a slide I've been talking about and I think it's absolutely pertinent to the last one. So like, when is not getting 100% good enough? Lots of students don't even get 100%. It's pretty hard to do, but it seems like in the vaccine space, that's what people expect, or it's deemed not good enough. And so I just put statistics from the CDC on seatbelts. I think we're at a day and time where most everyone really understands the value and importance of seatbelts. And this data was a little bit old, but I think it highlights the pictures. So most drivers and passengers killed are unrestrained, meaning they don't have their seatbelt on. And those among drivers and front seat passengers, seatbelt reduced the risk of death by 45% and cut the risk of serious injury by 50%. And so we all value this. We think yes, it saves lives, we get behind it, but a vaccine that's, 80% isn't good enough. So now I'm going to just transition to talk about the immunization information systems, or I'll call it IIS. In North Dakota, you guys have NDIIS. Some people call it Thor. I'm not really sure why. But you may hear that term. And then in South Dakota, we have SDIIS. So these immunization systems are managed by the Department of Health, and they're essentially computerized databases that record immunization information that people are getting in their state. And the state has the ability to capture those records from multiple people. And so it provides a better record probably than maybe what individual providers may have for people who seek immunization at different places. For example, an adult who needs to get shingles at the pharmacy, but they're getting everything else at their clinic, or those patients who maybe seek medical care at many different providers, the state record is probably going to be the best or most accurate place. These records are confidential. They do allow for population-based data analysis. And they work traditionally for those immunization records that are needed for things like school, or if there's an employment requirement, or daycare. The information is pretty basic: name, date of birth, sex, where I wasn't as familiar with this one, birth state and country of mother's name. That might have something to do with birth dose Hep B. And then just the information on the vaccine. I will say that it's particularly important that you are documenting people's official name, both in their electronic medical record, if you have that, and the state database. What we've seen at Sanford is a lot of duplicate records because maybe they're Elizabeth in the state system, but in ours, they're Lisa. So when those don't exactly match, it creates duplicate records within the state registry. And then I just wanted to call out, not everybody reports to the state registry. It tends to be done more cohesively for children because of the Vaccines for Children program, but definitely not for adults. I think we're making great strides in this space. So I'm working on a project right now at Sanford. We have what's called a bi-directional interface. So through our EHR, we send documentation of vaccines administered to the state. And when patients are seeing us, we have the ability, a query is run to pull us in, and essentially creates this thing that says, hey, in the state database, we have these vaccines, but you don't have them in your immunization record. And then we do what's called reconciliation and review them and add anything that's maybe missing on our end. Lewis Drug has that same bi-directional, but Thrifty White in North Dakota, who I'm working with, they only send, they don't receive. Some people don't have an interface at all. The coalition, we took a trip West River to engage with some key partners now that we're statewide. And I was actually really surprised how many were not connected. So they're either making a point to dual document in both the state and their medical record at the clinic or wherever they're at, or they may not do it at all. So that's some of the complexity around that. But the value of these systems, so they do allow us, or the state, an ability to really, look at the immunization rates across the states and the counties to evaluate maybe where some dedicated work is needed. It helps them monitor counties that may be at risk for an outbreak. So you think, let's say they get a case of mumps. I think we had that not too long ago, like down by Vermilion. They can look at that rate, right, and see what it is for the county to essentially get a sense of, do we have what we think is herd immunity in that county, or is it low and we might see a lot more cases? It can identify maybe barriers, might not have been the best word, gaps. When we looked at that county level data for the western side of the states, the Dakotas, we could see that. And so again, highlighting the need for work. And then regarding health equity, I know we looked at the information from GP Quinn, but this is from the North Dakota Department of Health. I was talking about those tabs at the top. So this one is demographics, and they have this for each of their dashboards. So again, they do the gender here, but they do Hispanic or Latino or not Hispanic or Latino, and you can see the difference there. And then they also do American Indian, Asian, Black or African American, other races, Pacific Islander, and white. And so again, if you wanted to drill down to your county and then some of this information, it would provide you a different picture potentially of where work is needed. We talked about it combining records from multiple providers, and then the state registries also provide forecasting. So it will tell you in the future when somebody's going to need another vaccine based on age. They can't really do it on medical condition because they don't have that type of information. And I don't know that everybody has an EHR with provider prompts. So we do at Sanford, but I didn't want to feel that everybody probably has that. So if they don't, then even more so, that forecasting from the state is super helpful. So there's only so many things we can do to improve rates. One thing we talked about, people probably not knowing that they're due, and so sending them a reminder letter or calling them on the phone to let them know can be very helpful. That is a very effective tool. Education, vaccines are always changing, so it's hard to stay up to date. And so educating not just healthcare professionals though, but also the public. So what can you do through social media or things like that to help spread awareness? We have to change the way we practice and not just update immunizations at wellness exams and really vaccinate at all visits. A key strategy or a subcomponent of that would be ensuring people when they come in for their flu shot that we're getting them their pneumos, their shingles, and all that stuff. I know it's super busy, but we have them. And so it stings when we miss that opportunity. A strong presumptive recommendation for vaccination is the best indicator for somebody accepting a vaccine. And so ensuring that people are presumptively recommending them is important. If they need another dose, scheduling that next dose appointment before the patient leaves. A lot of people just haven't even pulled their immunization rates. And so that can be really telling. When we did that at Sanford, there was a lot of disbelief. And I think, we all try to do our best. And so until you get that data, you're not really sure. We talked about increasing access through urgent cares and evening or weekend clinics. Standing orders is a really useful tool, is, challenging the nursing staff to really own that process, and for routine vaccines, just giving it if the patient needs it. And then be an advocate. So both, your friends and family, like I send a mass text to my close friends and family every fall, time to get your flu shot. And while you're at it, make sure you get your, any other vaccines you need, or also on social media. There's so much bad stuff out there on social media. There's not enough of us posting pro-vaccine stuff. So that is the slides that I have. Let me stop presenting for you.
Well, thank you very much, Andrea. That was a wealth of information. Very nice. Does anyone have a question for Andrea? While you're maybe typing or thinking about that, I just wanted to show you that in the resource document, there will be resources from today's presentation, both North Dakota and South Dakota's IIS links for them. And then this last one here, Carrie Sorensen is going to talk about here in just a minute. So if there aren't any questions,
there is a comment in the chat where someone mentioned, you mentioned the Thor for the North Dakota IIS system, and that's an outdated reference, and they don't use that anymore, I believe. So
thanks, Lisa. Yeah, I still hear it every once in a while. I'm always like, I don't know where it comes
from. I was thinking, Andrea, I had never thought about the other prevention campaigns or initiatives not having an opposition.
Yeah.
Until you mentioned that. That's, I don't know. Yeah. That will stick with me.
Very insightful. So, okay, well, I'm going to turn this over now to Carrie Sorensen. She's going to lead our office hours. So, Carrie, the floor is yours.
All right, thank you, Dee. Well, we are closing in on the end of our session here, but if we have a minute to just share that Halo algorithm that I had added to the resource document. And then if anybody else has any additional questions, just please drop those in the chat or interrupt me. But I thought this tool was really nicely ties in the health equity components that we want to be mindful of when we're vaccinating or offering vaccinations to our patients, that, not only taking into consideration their underlying health risk factors and chronic conditions, their age, but also incorporating consideration to lifestyle factors. And, Andre touched upon the considerations that we have with people that come from different races and ethnicities. And last week, we learned about the considerations of people and reasons why they might have vaccine hesitancy, and just being mindful of that. Andrea, in sharing those best practices, you really highlighted the fact that we need to be bringing the vaccination conversation to the forefront, but also just recognizing that maybe people have hesitancies for various reasons, and that bringing up that conversation and offering our stance of that we feel strongly in recommending these vaccinations, and they may not be willing to on that visit at that time, but maybe the next time they come back, they will be willing to accept the vaccination. So these lifestyle factors to consider, including maybe where they're coming from. Are they homeless? Do they have other considerations, maybe they're international travelers, or they're living in proximity with people that maybe bring risk to them. Now we've got the RSV vaccine coming down the pike, and people with grandchildren, puts them at higher risk for acquiring RSV. So just taking into account those different lifestyle factors, I really like this algorithm to kind of bring those things to the top of mind. So did we have any other questions pop into the chat?
Just a comment said, hadn't seen this Halo tool. Thanks for sharing. So, yeah.
Definitely. All right. Well, in closing, we always love your feedback. So if you would be willing to take a minute just to fill out the evaluation, there's should be a link in our chat section, or if you want to scan the QR code. And if you have any other additional topics that you would like us to present in the future, we're always loving those ideas. So we want to thank you for joining us today. And thanks again to Andrea for presenting all of that great information today.
Yes.
Yeah, thank you.
Yes.
Have a
Very
good day.
good.
Thank you.
All right. Bye-bye, everyone.
you.
Have a great weekend.
See you next
Bye-bye.
week. Bye.
Thank you.